Hi there, and thank you for joining me today for this webinar on the role of pelvic floor PT in perinatal care, how pelvic floor physical therapy supports perinatal health and helps prevent future dysfunction. My name is Keeli Gailes, and I am a full-time practicing physical therapist in Burlington, North Carolina. I am the owner and operator of Roots Physical Therapy and Wellness in Saxe-Baja, North Carolina. I got my degree, my doctorate in physical therapy from the University of North Carolina in Chapel Hill, and before that received my athletic training bachelor's from the University of West Florida in Pensacola, Florida. We will be addressing four main objectives today. The first is to inform all perinatal care providers of the ways pelvic health physical therapy can support maternal health in the perinatal setting, to discuss the role pelvic health physical therapy can play in preventative health, to encourage early referral to pelvic PT to allow for prevention of loss of function and income, and to advocate for improved patient education to help combat common knowledge misinformation. We'll start off here with just some basic information on how pelvic floor physical therapy can help your patient. Listed here are a number of very common reasons for referral to pelvic floor physical therapy, and many of these are prevalent in both during pregnancy and postpartum conditions. Highest among these include back pain, pelvic pain, incontinence, swelling, dyspareunia are also very common. Some of the ones that you may not think about referring to physical therapy as often or as a primary referral would include nausea, fatigue, insomnia, migraines or headaches, depression, and anxiety, but these are all conditions that we often are addressing simultaneously with some of these more commonly referred diagnoses, and I'd like to bring them to your attention so you do think about the role that physical therapy has in addressing some of these concerns as well. So the first question is, why is pelvic physical floor therapy necessary? Why do we need it? The obvious answer would be for that list of conditions that we just discussed, right? We would like to have our patients not walking around in pain or having incontinence or pain with intercourse, etc. But what I really want to talk about today are some of the longer-term lasting impacts and broader impacts that these conditions can have, and how physical therapy can be preventative in these conditions. This article cited here from the Journal of Women's Health Physical Therapy states beautifully here that women with pregnancy-related pelvic girdle pain are more likely to have complications during birth, experience a strained relationship with their partner, and have difficulty fulfilling their new role as a mother. These outcomes can also have a socioeconomic impact, as women with persistent pregnancy-related pelvic girdle pain have a higher prevalence of sick leave and healthcare utilization. So as a broader picture take on our role in impacting the society as a whole, we would like to be able to help ease the strain on companies by allowing women to work longer into their pregnancies without having these pain and other comorbidities, as well as specifically on those women so they are able to continue making income throughout more of their pregnancy safely, so they are not put at a disadvantage when the baby comes, and so they don't have to use their FMLA early on, so they're able to spend the majority of that time bonding with their baby in the postpartum period and healing adequately, because there's not enough time given as is. So we want to make sure that they maximize that time and are not having to use it early or losing income unnecessarily. This article specifically cites this impact for pelvic girdle pain, which is something we know physical therapy addresses very well. However, I personally believe, and I hope that some of you would recognize this as well, that you can replace that term pelvic girdle pain with low back pain or postpartum depression or hyperemesis or dyspareunia and see that the impact would be often very similar. And that by addressing some of these issues early on, we can really take a preventative role in healthcare for these women and decrease rates of postpartum depression potentially and other conditions that are very prevalent in this group. So as physical therapists, there are a number of ways that we address the concerns that were listed before. A lot of those involve assessing the person's motion and determining whether there are restrictions in their flexibility or their fascia, or are there weaknesses that need to be addressed, and addressing those through strengthening, stretching, etc. Manual therapy techniques, including decreasing spasms, releasing fascia, and helping increase the mobility of the joints, can be really important, especially early on. And then following that up with making sure that the patient has appropriate stability and alignment of the joints, as well as just helping them use better body mechanics in general. We educate on using supportive devices such as belly bands and SI joint belts, heel lifts if necessary, if there's a leg length discrepancy, which is a common occurrence that can lead to pain during pregnancy. Even mild scoliosis is something that is common that can lead to pelvic floor issues, which may not present outside of the setting during pregnancy in the postpartum state, or it may be minor enough that the patient doesn't complain. A lot of what we do also, however, is breathwork training and mindfulness that really can address more of the anxiety and depression around the peripartum state. We also do education on general sleep hygiene and nutrition, and encouragement and education on appropriate and safe physical activity. So here are just a couple examples of common interventions that physical therapy uses and the evidence supporting the effectiveness of those interventions. The first one here was a systematic review done on core and lower extremity strengthening for decreasing pregnancy-related low back pain and pelvic girdle pain. And the takeaway from that was that each study reported a reduction in pain intensity and location when compared to the control or alternate intervention. The second study here was a multi-center randomized control trial, which was 4 sessions of soft tissue massage techniques, and it demonstrated that those techniques, there were 2 different techniques that were studied there. One of them received a superficial abdomen and lumbothoracic massage and superficial skin rolling of the painful scar, and the second group received the same treatment plus abdominal myofascial release and direct deep scar mobilizations. and that both of those groups reported reduction in the stable chronic pain following a C-section. While I could go on with more studies similar to the prior two for days, I hope that most of you do not question that physical therapists do a fairly good job at reducing physical pain and other physical ailments. What I'd like to shift the focus to a little bit here today is to bring your attention to how we are also well suited to bring in some treatment methods that improve mental health along with physical health. There's a couple studies here. The first one is a meta-analysis that shows that those with moderate to severe depression who did exercise report greater reductions in depressive symptoms than other patients. Not groundbreaking here, but I'm assuming that most of the time when you're making referrals that your first thought is probably not to send someone to physical therapy for depression or anxiety, which I don't want to pretend it should be. But I do think it's important for us to think about how a multi-pronged approach can be very important for some patients, especially those who are more sedentary because of pain or because of some other physical condition that both the physical and the emotional parts could be addressed through physical therapy, along with counseling and medication when appropriate. The second study here is a systematic review on the psychophysiological correlates of slow breathing, which is important because as part of pelvic health, a lot of what we do is retrain or train breathing techniques. And a lot of that is slow-paced breathing, which can help with a host of conditions or symptoms. And this study here shows that the main effects of slow breathing techniques cover autonomic and central nervous system activities, as well as the psychological status, and that the behavioral outputs related to those changes are increased comfort, relaxation, pleasantness, vigor, and alertness, and reduced symptoms of arousal, anxiety, depression, anger, and confusion. I mean, this is good for everybody, right? But especially from a clinical perspective, my patients who may have had a traumatic first delivery and are very concerned going into a second delivery, whether they are going to be able to manage the pain or manage the anxiety, having had that first negative experience, or those who, as many of us have just heard horror stories, from everyone they've ever met about how bad childbirth can be. Often will have very high anxiety going into that situation, and they have told me, following the people that I've had the privilege of treating pre and post-natal, have told me that they did find those techniques to be very helpful in reducing those anxieties and allowing them to move forward with their birth plan to the extent that it was appropriate medically. And as far as it's great leading up to delivery and then in the postpartum phase as well, it can be helpful for them to have those techniques as a habit as they're dealing with the emotional and hormonal changes of new parenthood. And by no means do I feel that this is a replacement for any of the other techniques that we are using to help patients with postpartum depression, but just saying that it's a helpful additive in that toolbox of techniques that patients can use to help with their mental state at that time. Gestational diabetes is another area of concern that I don't think most people readily look to physical therapy to address, which is understandable, but we do all recognize that nutrition and exercise are key in the non-medical management of gestational diabetes. What might be overlooked is the idea that a lot of women tend to avoid exercise during pregnancy because there is this old school fear that movement could potentially endanger the baby. And if they don't have this fear, a lot of women also are experiencing low back pain, pelvic pain, as we've discussed earlier, but may just be of the belief that that's normal and that they just have to endure it. And so they don't bring it up to a level to raise the concern that would necessarily create a referral to physical therapy. But you may find that if you're seeing some of those concerns, even if they're not voiced loudly, in combination with a patient who has a fear of movement or is experiencing gestational diabetes, that it's worth that referral. Nutrition is within our realm as physical therapists. We're not pretending to be dietitians or nutritionists, but we do have enough education about it to help guide patients within what are the acceptable, understood norms of nutrition. And sometimes we are able, because of how uniquely we are situated to see people regularly, to pick up on some things that they may not express to other providers. For example, I've had a couple patients that have had pica and have not said anything to their OBGYN or primary care providers, but have asked me questions like, is it normal to want to eat your carpet freshener? And I've had to help them break down why that's not normal and what it could mean about what's going on in their body and how we need to look into it to figure out where they may be lacking something nutritionally that could be affecting the fact that they also have other symptoms and why they're seeing me in general. But I think that there's a lot of those little subtleties that we are able to pick up on as PTs that really could be beneficial for patients who have gestational diabetes or other minor nutritional concerns. People who are having severe nausea that won't go away often are helped by things like the breathing techniques that we discussed earlier, because it helps calm that vagus nerve, which affects your breath rate, your heart rate, and also impacts the GI system. And so just kind of thinking out of the box and making sure that we don't overlook the potential role that PT could play in some of these fringe areas, I guess you could call them, of the physical realm. In this next section, I would like to discuss how pelvic PT can be instrumental in helping prevent long-term conditions and minimize the impact of conditions that do exist during pregnancy and the postpartum period. So there's a really interesting study done here in a large postpartum group that was on the prevalence of urinary incontinence. And it demonstrated that 45% of women experienced urinary incontinence at 7 years postpartum, and that 27% who were initially incontinent in the early postpartum period regained continence, while 31% who were continent became incontinent. So I don't think it's surprising that some amount of people who were initially incontinent regain continence. But what is more surprising is that the 31%, which is higher percentage of people who were continent originally in the postpartum period became incontinent. And the question is why? And there's a few studies, one of them below here, that's demonstrating that the reason is that they have poor strategies for transferring loads, which is PT speak for basically they are not using their body in the best way that they could be, or that their body is not working the best for them. These non-optimal strategies for posture, movement, and or breathing create failed load transfer, which can lead to pain, incontinence, and or breathing disorders. The way we as physical therapists address this is we find what's not working. We figure out, is it that they have a diastasis recti, and that's not allowing the force to transfer appropriately across the front of the abdomen, or do they have an SI joint dysfunction, and that's put their gait pattern into a funk, and that's creating muscular imbalance. And we tease out what is going on there, and we help correct for that and get them moving on forward from that point with improved strategies for transferring loads. So the idea is that the earlier that happens, the easier it is to get it back on track, because what happens is early on, you may only be up against just teaching a person how to move better. In those instances, you can often do that via a webinar or via a group class, which is low cost, low impact, easy for that person to get there for just a few sessions to learn what they need to learn. If it goes years and years down the road and isn't addressed early on, now we're dealing with how to teach the new strategies, but we also have to deal with fascial restriction, muscular imbalances, postural changes, stiffening with age, and it takes a lot more manual therapy and longer duration of practicing therapeutic exercises before that person is going to get the same result that a person would have been able to get early on. And sometimes there's also changes in the body that are irreversible. We may be able to improve the symptoms, but we can't necessarily go back and change the physiology, such as pelvic organ prolapse. The longer that goes untreated, the harder it is to fix. They may end up needing a surgical intervention, whereas if it had been addressed within the first year or two, it may have been that person would have healed while their connective tissue was still rebounding in that postpartum state, and that they wouldn't have ended up needing that surgical intervention down the road. So I'm going to piggyback off of what we were just discussing in the previous slide with the diastasis recti and pelvic organ prolapse here. I'm lumping these two together because in my clinical practice, I think of them similarly in the fact that they both are primarily concerns with the connective tissue and the myofascial system that are progressive over time if not treated early. We see in the top study here that they demonstrated that there is a higher percentage of people who in this study sought help for pelvic girdle dysfunction than there were in the control group. It was 74.4% for those seeking help and 50.9% in the control group. Now, we can see that there were patients who were not seeking help, who were not symptomatic, who did demonstrate diastasis recti. So I don't want to make this statement that, everybody that has a diastasis recti is eventually going to have dysfunction. It's quite possible that they won't, but what I'd rather say is that an ounce of prevention goes a really long way for these particular conditions, and they're very prevalent conditions. And while these people may not necessarily need to get one-on-one treatment for physical therapy if they have a diastasis recti, but they do not have pain or dysfunction, I do think that they would absolutely benefit from some very basic functional movement training that could be taught in a group environment or from a class, whether it's virtual or in person. That we would start to see some decreases in the prevalence of some of these conditions if people understood the ramifications of how they move and use their body on the potential for those conditions to worsen over time. The second study here is just demonstrating that we can do a lot about decreasing symptoms of pelvic floor dysfunction and lower back pain through some fairly simple protocols. This one included 8 45-minute live group sessions and a home exercise program to be performed at least 3 times per week, and they saw significant relief from that. So it doesn't have to be one-on-one, hours on hours, but something should be done for patients early on who are demonstrating early symptoms or low-grade symptoms of diastasis recti or low-grade pelvic organ prolapse to help prevent those from worsening over time and getting to the point where they will require surgical intervention. Especially since we know that unfortunately about a third of women that do have surgery for pelvic organ prolapse will need to have multiple surgeries because they have often failed. And hopefully the science is improving on that. And we're also understanding that those people, when they need to get the surgery, also need to be getting PT either before and or after they have those surgeries so they can relearn how to use their pelvic floor muscles appropriately so they don't have a failure of those surgeries. So that's my soapbox there. I just really hope that we can do a better job of educating people on how to use their bodies as well as fixing whatever that immediate concern is. This last section here is to just further encourage that we improve our patient education, because the reality is that the patient has the most ability to make an impact on their physical being, and if they don't know what power they have, then they can't make that impact. The problem is that these patients don't know what they don't know, and that patients who are in pre-contemplation don't make behavioral changes. So the other issue is that physicians, nurses, and other advanced practice providers do not have enough time face-to-face to provide all of the education needed. And I see the very diligent effort that has been made by many providers to provide very in-depth handouts, but I also talk to the patients that I can see have received those handouts who often have not read them and don't comprehend the information in them. And so what I would like to propose is that we use more group classes to help educate on the topics around pelvic health, and also help break down the stigma around some of the topics that are uncomfortable, including incontinence and pain with intercourse, etc., and to allow for re-education on some of these traditional wisdoms. Some of the quotes that I have heard from patients over the years are, once you've had a baby, it's normal to pee a little every time you laugh, cough, sneeze, etc. Back pain is normal during pregnancy. If you have multiple pregnancies, then you're just going to have prolapse, and that you should practice your Kegels while on the toilet. And these are all myths I would very much like to bust. And I think that we should be teaching people in a way that is accessible for them. There was a study that was done called From the Core to the Floor, utilizing a webinar to provide pelvic health education. And while this was a small study, it demonstrated that there was an improvement in the understanding and ability to perform, for example, Kegels, at the end of that webinar series, and that's some of the low-level entry access to this kind of information that could go a long way for some of these patients. I wanted to share with you a couple of studies here that demonstrate the evidence of educational interventions that we use with physical therapy. The top one here is very, very common, teaching women how to better hold the baby in a way that is biomechanically sound and minimizes the load on their body. This study was actually done in nulliparous women, and even in those who have not had a baby, it did show that those that were holding the infant mannequin in their arms versus holding it in a carrier or holding nothing reported the greatest pain when they were carrying the infant without a carrier. And we can extrapolate from that women who are also in a postpartum period who may not have the same structural integrity as someone who has not had an infant recently would likely have even higher pain reports than the women in this study did. The second study here is interesting because it is right along a line where physical therapy and lactation kind of overlap, and I do not in any way want to step on lactation consultants' toes. They are wonderful, wonderful people, and I very much value them, but this is a great study that just showed that physical therapy interventions could also potentially help in affecting clearing blocked milk ducts that had not responded well to self-clearing methods. In this study, they used a combination of heat, ultrasound, and manual techniques, as well as patient education, to help clear clogged milk ducts and decrease the pain and discomfort that's associated with that. But the important part for this is that patient education part of it is that these patients afterward felt much more confident in their ability to self-manage in the future moving forward. And part of what I would like to do with my classes as part of my company is to eventually expand them into realms outside of just physical therapy, but including lactation consultants and other related fields involving the peripartum arena, so we could really give these patients the best knowledge base that they can get to help self-manage and advocate for themselves moving forward. Thank you for joining me for this presentation. I have really enjoyed being a part of this group and I've learned so much from you all, and I hope that you were able to take something away from this presentation of some interest. I also thank you for your patience with all of my ums and uhs. I have been fighting off an illness for the last couple weeks while I've been working on this presentation, and my processing time is a little bit slower than normal, so I apologize, and I thank you for sticking it out there with me. Below here you can find all of my contact information. I'd really love to work with you on any projects that are involving perinatal health, and I enjoy teaching classes for students in different medical fields or for patients. I can help connect you with PTs in your area if you're looking for a pelvic PT to refer to, answer any questions or collaborate in whatever way is necessary. And I enjoy getting to know you all more in the future. Here's the first page of references, and references can also be found throughout the PowerPoint on the appropriate page. And here is another page of references, which again can be found on the appropriate slides as well. And finally, I would like to thank openclipart.org for having images that are truly royalty-free and available.